Very good morning, and I'm Karthik Rao. I'm a physiotherapist, and today we are going to discuss about the assessment protocol. How are we going to assess? Why we are going to assess? And what are the things that we are going to look at? So this would be my part. And before, what we are going to do now is we're going to do like in two parts. One is I'll take you through the assessment form and also take you through the process why we are doing assessment and give an explanation on that. The second part would be we are going to look at the form and then do it practically. Okay, because we are in different locations, it would be difficult to combine a presentation as well as a demo at the same time. So let me take you through the form first, and then we will do the practical aspect later. The first thing that we're looking at, why do we need to do the assessment? And apart from the basic information, we need to have three kinds of information. So there are be some questions or some details that we are collecting, which will help us to decide whether this wheelchair is suitable or not for this particular individual. So we're looking at an inclusion or exclusion based on this information that we're getting through the assessment. The second thing is when you are taking assessment, we are deciding like what should be the measurement of fit that are required. For example, based on their size, we might choose a bigger wheelchair and things like that. So that's some of the data that we are collecting through the assessment will help us in guiding with the size of the wheelchair, the changes, the modifications and things like that. And certain information that we are collecting will help us with the user training, because once we have given them, we have decided that this is the right fit for them with these kind of modifications, then we also need to understand that it's not like once we give it to them, it's not like they are able to use it from day one. So they might need some training related to how to use this wheelchair, and that's what we need, some information related to their physical capacity and probably other things as well, which will help us to determine or customize our training according to their level of performance or capability. So this is the assessment form that you will be seeing in the website as well, in the link that you have seen. So apart from taking the demographic data, which includes all your basic information, we are also looking at the height and weight and things like that, because RISE has restrictions in terms of that. And we can look at, then we look at the intended usage. What is the full-time or the part-time? How is the person likely to use the wheelchair? And based on that, we might give some recommendations. And the next thing is who is the primary care professional? How did the person know about RISE, and who is it going to refer to? Because it is important for us to know that when we get through this referral, it's important that the person is able to go back to that person and check it out, because we cannot be there all the time. So it's important that we have a liaison with that person as the physician as well, who is referring for RISE as well. And we look at all this information. These are basic in nature. The next thing we would look at the subjective evaluation. We're going to find out what is the diagnosis. Most of the times we find it is a spinal cord injury, but it could be other cases as well, like there could be a congenital spinal issues, or it could be issues related to tumor or trauma. So we're also looking at the onset, which could be an injury, or it could be a slow insidious onset like a tumor. Okay, or it could be some other conditions in which the bones are weak, or there could be muscular dystrophy and other conditions. So we need to identify what is the diagnosis and if there is a subclassification. Because if it is a spinal cord injury, then we usually refer back to the Asia classification to identify whether it's a complete or incomplete and what is the level of injury. So those kind of information is basically put into this subjective evaluation. And the last thing would be understanding about the assistive devices, because assistive devices will help us to know what is the current capability. One of the important parameters for inclusion is the person should have a history of standing even after injury, and that assistive devices will also help us to know whether they are using it and are they standing on a regular basis or not. We also look at medications such as antispastic medications or anticoagulant or anti-epileptic, because these might have an impact on the use of the wheelchair, as well as to help us to understand what is the current level of capability of that person. Because sometimes when they are under medications, they are drowsy and sleepy, and it is not a good thing to be standing on a wheelchair when you have had an anti-epileptic medicine and then you are like drowsy. okay, and there's no one around, so that could be dangerous for the person as well. So having an understanding of these medications is important. And then we get into what is the standing history of that person. Is they standing regularly? And by regularly we mean like at least three uh, three sessions per week, okay, and at least 30 minutes duration of each standing, okay. And this is what we mean by regular standing history. So then we are also collecting like date of a previous standing session, how long it was the person was standing, and what was the mode of standing. Now, why do we want to know about the mode of standing? Is sometimes people assume standing to be any upright posture, and when that happens, if a person is being held by two people on both the sides, or the person is just clinging onto a window or a grill, and without actually putting any weight through the legs, it cannot be termed as standing. There has to be some amount of weight bearing through the limbs. And so when two people support, standing with two people support, or standing clinging onto the, like almost like hanging onto the stationary support, cannot be considered as standing. So standing has to be something, either it could be through a standing frame, it could be through a calipers, and or leaning on a wall or things like that. So that would ensure that the person has got enough weight bearing through the bones and the osteoporosis has not set in. The next thing that we look at is the pain history, and we try to identify what is the if there is a pain history involved. If the person has pain, where is it? So we're looking at the side, the location, the duration, and severity, because sometimes it has both repercussions on. If the person is not able to feel the pain, then the person is more prone for developing pressure sores. So that is something that we would also want to know. And the other extreme is if the person has a pain and the person is not in a position to use the wheelchair. If it is very severe, or it is something which is interfering with his ability to sit or stand, then wheelchair may not be recommended at that point of time. We might probably investigate further and try to identify what is it that is causing the pain and what needs to be done. And based on that, so it is a judgmental call that we might have to make, whether this person is ready for using the wheelchair right now, or maybe it can be done after some time once the pain is resolved. We also check about the involuntary movements. The involuntary movements are movements which are happening without the conscious control. So it could be as mild as a small tremor, to it could be as big as we have full range arm movements. So which can again be challenging, because if the person is not able to control themselves, like we have people with different conditions called dystonia, with arthritosis, and people like that, or so these people may not be able to control the wheelchair in an effective manner, and sometimes they may accidentally hit the levers, and that may make them stand or sit, and we don't want those kind of things as well. So it depends. Again, it's a judgmental call whether the involuntary movement is small, that it cannot interfere with the use of the wheelchair, or it could be like so big, and then sometimes we might have to decide, like, is it okay if this person can use the wheelchair, but there has to be a caregiver with them all the time, just to make sure that there is nothing happening untoward happening. So these are the reasons why we would need to know about the involuntary movements. And then we look at the known medical conditions. The known medical conditions, like your hypertension, your lung-related problems, obesity, your peripheral vascular disease, because so all these things will have an impact on the choice of wheelchair, the size of the wheelchair, and the duration of standing. So these are not like absolute contraindications. When we talk about contraindications, these are terms when we use, like this person should not be using the wheelchair. It is not like that. Some of them, yes, okay, but not all of them. So then we would like to know whether this person is able to do, and probably it's almost like, even if you just buy a wheelchair and you take it home and you're all fit, and then you stand on it for 1 hour, then the person may have some negative issues, because they're not used to standing for such a long period of time. So all of this has to be considered. When looking at hypertension, they probably need to take it step by step. And then the chronic pulmonary disease, there could be issues with endurance. And obesity, again, because the weight of the body is going to be more than what the legs can take. So that is something a judgmental call that we have to take. A peripheral vascular disease is usually clot or something, or like varicose veins and things like that, in which the blood stays in the foot, and so there is a risk of a clot formation, and that can affect which can spread to the. I mean, if the clot is dislodged from the blood vessel, it can go to the heart, it can go to the brain, and can lead to very fatal complications. And we also need to look about osteoporosis, because if the person has not had the history of standing, then the person may not have very strong bones, and so this can lead to fractures. So the person, then osteoporosis is almost like a contraindication that you will have to always check out. If the person has an osteoporosis, then this person is not suitable for a rise standing wheelchair. Okay, so that is what we have to check as well. And then orthostatic hypotension is a condition in which your blood pressure drops when you get into vertical position. So when you're in lying position, when your head, your brain, and the heart are all in the same line, the blood pressure is fine. But the moment they get into upright positions like sitting or standing, then the blood pressure drops. Then this is something that needs to be addressed, and we cannot straight away start using wheelchair immediately. But these people, if they are taken step by step and there is a procedure to that, and they might be able to use it at a later date. And we are also looking at past surgeries or history of fractures, because they are all maybe related to the use of wheelchair. Is the person able to sit appropriately? If the person had a fracture in the leg, then we need to know that has it healed? Is it more than 3 months back, or is it like something fresh? And so we do not want to aggravate a condition again. So all this information has to be noted down, and then we also specify the location. And then we look at the wheelchair mobility. The wheelchair mobility would be where we're looking if the person is able to do a wheelie. If the person is able to, so we have a grading there, and we will be sharing with you all this information about how do we grade what is good, what is fair, what is poor, and what is none, by means of a guide at a later point of time. So good means like they're able to do the wheelie and they're able to rotate. Okay, so they're able to do both at the same time. Fair means they're able to hold the wheelie and lift the front part of that, but they're not able to rotate, so that would be fair. And if it is poor, it means they're able to momentarily lift it as if they're trying to cross a curb. So that would be a poor indication. And none is they're not able to do the wheelie. So we're trying to grade them based on this, and because this will have an impact on the use of the wheelchair as well. So we're checking about the bone mineral density, which is through a DEXA scan. DEXA scan is X-ray, as a special kind of X-ray, which is done to check the density of the bone, and that will give us an indication of the osteoporosis. Osteoporosis is a condition in which the bone density is affected, and if it is lesser, it is called osteopenia, or if it is too much, it is osteoporosis. So osteoporosis is a contraindication, and these persons are not suitable for using the rise standing wheelchair. So that's what we are going to check out. So this can be done through scans, DEXA scans. And the next thing that we are going to look at is the higher mental function. We are going to check out if the person is able to, is he attentive, is he able to respond to questions, how good is the attention, the comprehension. And so when we talk to the person, when you ask them questions like how are you, what are your feelings, you will have an idea about what is the comprehension of the person. We also look at orientation. We see whether the person is able to orient to date and time. Does he know what day is today, what is the time now, and things like that. Even if it is closest to by the hour, is fine. And so we're looking at the orientation of the person. And then I look at short-term memory and long-term memory. The short-term memory could be something like what did you have for breakfast and things like that. And long-term memory would be what is your date of birth or your wedding anniversary and those kind of information. Why do we need all that? Is we need to know, like, is this person capable of using a rise standing wheelchair on his own, or should it be like we need to have a caregiver? Because sometimes it is important that if the person themselves are not able to do, a rise can still be prescribed if the on the basis of the caregiver's ability, because then the caregiver takes the lead and they know like this person will benefit from that. At the same time, we also have to train the caregiver on the different aspects of using the wheelchair. So this higher mental function will give us that kind of understanding about the user. And then we look at the sensation. We look at the pinprick and light touch sensation, mainly through the weight-bearing areas in the lower limb, wherever there's a contact, wherever there's a risk of developing pressure source. So the ischium, the greater trochanter, the sacrum, and the patella. So you're going to check on all those 4 areas just to make sure the patient or the user has the sensation, so that the person understands that there is a need to shift his body weight and adjust it so that he's able to relieve his pressure. And then we also check about the past pressure ulcer and the active pressure ulcer. The past pressure ulcer will give you an indication of what was the position the person was assuming and what are the limitations they have in terms of movement. So we look at both the side, and then we look at the grade. The pressure ulcers based on whether it's just at the skin level or it is deep inside. So we have 4 grades there. And based on the grade, you will note down what is the extent of which the past pressure ulcer has gone. And sometimes at grade 4, it would have also impacted the muscles and bones, and that will also give you an indication about the bone strength as well. The active pressure ulcer is definitely, again, that we need to be sure of, because at this point of time, the person again becomes ineligible to use RICE at that given point of time. Again, we'll have to probably review the situation after 15 days or after a month based on the severity of the pressure ulcer, and based on that, we can probably recommend the person may be fit again to use the wheelchair at a later point of time. Then we also check about the edema, because this again might have an impact on the person's ability to tell you about how much dependent he is. I mean, we are looking at dependent edema. We're looking at what is how long is he stays in that particular position, and this will also have because we might have to measure the edema, and based on which we might have to make changes in the fitting. So that is why we will have to measure the left foot, the right foot, the left mid calf, and the right mid calf, the common areas where you can have edema. So dependent edema means the edema is in a place which is gravity dominated. So which means it's on the lower limb, especially when you are sitting or standing. And the pitting means when you press the edema, when you press the part, it makes a small kind of groove. So that would be a pitting edema, and then we measure the circumference. And also we check what are the pressure relieving methods that the person is already using. And because most of the time it happens that the wheelchair user who wants to use RICE standing wheelchair is not going to be trying RICE for the very first time. It's most likely that the person might be using some other wheelchair, and then he's looking to see the benefits of RICE and then want to move over to RICE. So the person will already have his own methods of pressure relief, and we can also tell them or guide them how it can be done. Next thing that we check would be about the neuromuscular status, which is about the muscle tone. And in the muscle tone, you will find we use a scale called the modified Ashworth scale, and in which you check the resistance to a passive movement. Okay, when we're trying to move, and whatever the person is the tone allowing us to move or not. So we see that through mainly to these groups, your the flexor and extensors in the shoulder, abductors and adductors, as well as for elbow, as well as for the wrist and forearm. So these are the things that we check, as well as for the lower limbs. We'll look at more into this in the practical demo session. And for lower limb, we check for hip, knee, and ankle. Then we also go for the passive range. Passive range is if I am able to move my limb like this, it is active. If somebody else is doing it for me, it is passive. So we are going to check even if the person is not able to move the limbs, especially the lower limbs on their own, we are going to check the passive range, because the passive range will give us the indication of the range of movement present in the joint. So is this person is able to move the joint to a particular range or not, and that will again have an impact on the prescription of the wheelchair. If the person has a good range, then the person becomes eligible for using the RICE standing wheelchair. And so we check the hip, knee, and ankle for the passive range of motion. And then if the person has any tightness, contracture, or deformity, then we will also note down the location and the side. So what is a tightness? A tightness is a decrease in the length of a muscle. So now every muscle, as you know, like for example, I'm bending and stretching. So when I'm doing that, the muscle actually becomes shortened and it becomes lengthened. So there is a movement that is happening in the muscle also. And this, when it is restricted, which means the muscle is in a shortened position and it is not allowing lengthening, it is called tightness. It is for the tightness. It's called tightness of the muscle. And what you see is in tightness, when the person might not be able to do it on their own, but when you actually stretch the muscle manually as a therapist, when you do to an external force, then the muscle yields. The muscle allows the joint to be moved through full range of motion. So that would be a tightness. And contracture is when the muscle does not allow that. So which means the person is not able to do there on their own. And when we try to manually move it, the muscle is so strong, so tight that it is not allowing the joint to be moved through full range of motion. So that would be a contracture. And then the deformity is a state in which the bones are also involved. So the bone, because of a constant tension from the muscle over a period of time, the bone also changes its shape based on these forces. So that is a tightness, contraction, deformity. At the tightness level, we can definitely work it out and improve it. Contracture and deformity requires additional intervention in terms of surgery. So that might be required. So again, so this will help us decide whether the person is suitable for using wheelchair or not. And then we also check the leg length discrepancy for the femur as well as for tibia, and both for the left and right side. The leg length discrepancy essentially is the difference in length of the right side and the left side. And so this will also be an indication which will help us to decide like what adjustments need to be made to enable the person to use the arise. And then we look at the mechanical assessment tool. We are going to look at observation of the person's posture in terms of pelvis, trunk, and hip. Okay, so in pelvis, you're looking at different aspects. So we'll go into more detail of that. So when we're looking at pelvis, I'm looking at three components of pelvis. One is the tilt. The tilt is when you move forward or backward, and that is the tilt that you see in terms of the pelvis. And then is the obliquity. Obliquity is the front view. If this is my pelvis, if one side is higher and the other side, so that is the obliquity. And the third side is rotation. Rotation is forward and backward. Okay, so we're noting down if it is the left side is forward or the right side is forward. And based on this, we make a note in the assessment form. So this will be for the pelvis. And then we look at the trunk. So when you look at the trunk, we're looking at whether the person is like kind of a slouching position, or the person is like sitting upright, or is like leaning too much forward with the belly. So these are the different positions that are possible, and so we have to note down that as well. And then we also check about the scoliosis. The scoliosis is the side bending that we see of the spine, and we note down. We usually note down the convexity, the part in which it is on the curve. The convexity is noted, and then we note down whether it is in the thoracic part or the lumbar part, and which side it is, right or left. And then we also look at the rotation from the top view and see for the trunk whether the person is able to, when leaning on the wall, if the person is able to maintain a very good alignment, or it's like one side is forward compared to the other. And when we check hip, we look at the abduction and adduction, and external rotation and internal rotation. So these are the positions that we are checking. If the person is able to maintain a neutral position, or there's some deviation here and there. And then we're also looking at wind swept. Wind swept is when one side gets into external rotation, the other side gets into internal rotation, like what we call as like the Gandhiji position. Okay, so that is kind of a wind swept position. Wind swept is actually when you say like if there is something static and then there is a wind on one direction. Okay, when there's a wind swept, what will happen is if I have two things, okay, pointing towards this side, then this will fall in this side, this will fall in this side. Okay, so that would be a wind swept position. Okay, and then we also check at the static balance, the sitting balance. If they're able to sit, are they able to sit and reach? Are they able to sit and pick up objects from the floor? And based on that, you grade them from poor to good. And then we look at the mechanical assessment tool. The mechanical assessment tool essentially is a guide which tells us when we observed that in the mat assessment, we identified there are some issues with the tilt or the obliquity. We are trying to see is how much is that we're trying to quantify it in a way, in saying like how much is this affecting the person and how much of it is correctable. Is it like am I able to use some force and get it aligned in the first place, and then based on that I decide like what is the postural support that I might have to give them. Do I have to provide them extra padding, and what should be the amount of density of the foam, I mean what should be amount of padding, and so all of that will help us to decide whether what are the modifications that are required. So we are looking at the mechanical assessment tool for all of this, for the SKM, for the PSIS, and we'll go into this when we look into the demo session. Okay, so we are looking at two things. One would be the amount of force that we are applying, and the direction, which direction it should be applied, should be towards the left side, towards the right side, and things like that. And once we have gone through all the entire assessment, then we identify these are the problems, and based on that, we note down whether this person is selected. Can he proceed and recommend the use of a rise standing wheelchair, or is it like there are something like I gave you examples of active pressure ulcer or things like that, where the person is not ready now, but maybe available or maybe fit to use a rise at a later point of time. So that in that case you will mention it as selection postponed, and then if it is like osteoporosis and conditions like that, or the person does not have a standing history, then you will go for not selected. And then you justify the reason for that, as well as you note down what could be the short-term goal to be able to maintain, to be able to sit, or to be able to move from sit to stand and things like that. And what is the long-term goal? What can be expected from using the wheelchair? And then we give the assessor details there. Yeah. Can we have people for demo? At least two people in the same place. Right now, we might not require them to use the wheelchair because we're just in the assessment mode. But if you want to show them how you stand and sit, I think that would be helpful. So as you can see, there is a knee lock, which is very important here. On standing, the person maintains an angle of 80 degrees with the ground. Can you stand again one more time?
Yeah.
So there's a gas spring that needs to be calibrated. We'll discuss more about that at a later stage, according to the weight of the individual, and that helps in assist standing. Yeah. Thank you very much. So we are going to look at the form now and see what we're going to assess, and we will start with the edema. Yeah. So we are going to look at the edema in the calf region as well as the foot region. So this is what we're going to check. So what we are going to measure is the circumference of the calf. Okay, and we want to measure the mid calf. And for that to happen, okay, so we have to measure in the point, and basically we're going to compare the left and right. Okay, and let's assume he's rolled up his pant. Because the pant is tight, he's not able to do that. And so we have to identify a point in the mid calf. Okay, so we'll start. Can you feel the patella tendon? Yeah, and from there you can measure till the ankle. You can, yeah, and then identify what is that, and can you just divide it by 2? And that is the point where we are going to measure. Okay, we are going to measure the circumference of the mid calf. And once we do that, we are going to compare that with the other calf as well. You can check it from the patella tendon to the malleolus, because bony prominences help us in identifying the landmarks. That helps. And then divide by 2 and then choose the same place. So you got a equal score?
Yes, sir.
Yes, thank you. And then we are going to check about the foot as well, because again, pedal edema is very common. And so we are going to check from the heel to the toe. We're going to measure the distance, divide by 2, and identify a midpoint, and then we are going to measure the circumference. Then compare with the other leg as well. Yes, sir.
Yes.
Thank you. And so this would be for the edema. This is the measurement of circumference, and the other thing that you will check is whether it is pitting or not. So again, if that is obvious only when there's a edema there. So you will just press with your thumb and see if after you remove your thumb, or let's say you hold it for 3 seconds, and after that when you remove your thumb, you see a depression being maintained there. Okay, so that is what you will be measuring. And then we go to the next assessment, which is the muscle tone. And we are going to use a modified Ashworth scale. We'll just check one for the upper limb. We are going to measure for the shoulder, for the elbow, forearm, and wrist. And for the lower limb, it will be for the hip, knee, and ankle. So we'll check with the shoulder first. Okay, and then we are going to, can you just lie down on your side, on your right side? Yeah, and it becomes easy when you are checking for the flexion and extension of shoulder. Now we are going to check the left upper limb, and we are going to focus on the shoulder. Mr. Dinesh, can you just go behind Mr. Manish? You can have one hand on the shoulder and one hand on the forearm, and probably with the elbow bent to 90 degrees. Yeah, so that just that will help him to relax as well. And then we can take the limb to shoulder flexion, total full flexion. Yeah, and this is what you check. And there are grades in when we are doing a passive movement. We have grades like 0, 1, 1 plus 2, and 3, which is again, as I told you earlier, we are going to check this based on the modified Ashworth scale. And what it tells you is when the person is moving. Right now, Mr. Dinesh is moving his limb. So, Mr. Dinesh, do you see any resistance from him?
No, sir. He's normal.
Yeah, he's fine. So there's no resistance. But when there is a spasticity, we will find a resistance, and therefore the person as if it will appear that the person is not allowing you to move. And then what we see is there is a based on the grade 0 to 3, you will find the grade according to that. Grade 3 will be the one in which the person is totally stiff. Okay, 0 is a person totally allowing you to move, and grade 3 is a person totally stiff. Okay, and that means the person. So we'll have to, once we identify the extremes, this is now 0. The person is allowing him to move, and 3 is the person is totally rigid, not allowing the limb to be moved at all. And then we find then it becomes easy for us to score the other things, which is 1, 1 plus, and 2. Okay, so now what is 1? When you start moving the limb, you find a small catch. Okay, it's called a spastic catch. It's almost like when you're moving till one point, it is free. Okay, and can you just move it, Mr. Dinesh, can you just move it around for let's say half of the range? Yeah, and till this point, half of the range, stop. Till this point, you may not feel any resistance, and then you feel a small catch, and after that, you're able to move it. Okay, so yeah, please move further. And then the remainder of the range, you will find some resistance. Okay, so that is how you grade it as 1 and 1 plus. And if the resistance is more than 50% of the range of motion, then you score it as 2. But again, it is still possible, and 3 would be a total resistance. So you will check for the elbow. This is for shoulder flexion, and now we'll do the same for shoulder extension. So we again bend the elbow to 90 degrees, and now this time we're going to take it back. Okay, so we are checking for the shoulder extension. Okay? Yeah. So what we have to understand now is when we're talking about the movement, we are talking about shoulder flexion and extension. Okay, but what we are checking is the muscle tone. Okay, and the muscle tone is likely to be involved when it is giving a resistance when it is being stretched on the opposite side. Okay, so you will find that when the person is trying to move it in extension and the extension is not being allowed, it is more likely that the shoulder flexors, okay, is affecting. Okay, and it's the other way around. So let's check for elbow. So, sir, can you just bend his elbow? We can also do this in sitting, but right now, since he's lying down, we'll just continue with that. Yeah, you bend his elbow completely. Okay, and now slowly move towards extension. Now, when we are moving towards elbow extension, it is the biceps, which is the elbow flexor, which is going to resist this movement because it has an increase in tone, and this is going to resist elbow extension. So what I'm suggesting, so then I'm trying to clarify the earlier point. When you're actually moving the elbow through extension, we are not looking at extensors, we are looking at the flexors and see whether the tone is, what is the amount of tone, whether it is 0, 1, 1 plus, or 2 or 3. We'll check for his lower limb, we'll check for hip flexors, the same way we did for the shoulder flexors. Okay, and then we can also do this in supine position. If it is difficult for you, we can check it in, yeah. Can you bend his knee and take him to full range of hip flexion?
With the bend knee, sir?
Bend knee and then take hip into flexion, full range, full hip flexion. Yeah, so we're checking for full hip flexion to extension. The range is usually 0 to 135 degree. We will take it to 50% knee flexion. Yeah, and yeah, so you get that, and if you see a catch and then you feel resistance, can you just, Mr. Manish, can you just give him some resistance, but allow him to move? Okay, just kind of give him around 20% of resistance. Okay, let him push you into bending your hip, but you try to resist lightly, not too much. Okay, so that is how you will look at the Ashworth scale. And for 1, there is end range resistance, and for 1 plus, you will have a resistance which is less than 50%, and for 2, a considerable resistance which is more than 50%, and for 3, there is total rigid. It's not, the person is not allowing you, or the limb is not allowing you to move into total extension. Okay, so we do that for hip, then we look at for the knee, and then we look at for the ankle. Okay, so again, this can be checked in lying position as well as in prone position or sitting position. So then for the passive range of motion, we are going to check it with the goniometer, and there are different points that we're going to check. And we are trying to always relate this to more with the Arise wheelchair. So we are going to focus on hip flexion, extension, abduction, adduction, and then knee flexion and extension, and then ankle flexion, extension, ankle dorsiflexion and plantar flexion, along with inversion and eversion. Okay, and we can also look for the internal and external rotation for the hips. So these are the things that you can check. Let me just, can you just demonstrate for only for the hips, sir? Hip passive range of motion for hip flexion, extension. Yeah, please bend the knee. Yeah. Yes. So yes, hip flexion, hip extension. Okay. Abduction and adduction. So abduction would be moving outwards, and then adduction, and then internal and external rotation. Bend knee, bring the foot inside. Yeah, this is external rotation, and this would be internal rotation. So again, we are going to use the goniometer to identify the range that is involved, and so similarly, we are going to measure for the all the other joints like knee and ankle. And then we look for leg length discrepancy. So we're going to measure the length of femur as well as for tibia. Can you use the inch tape, sir? Yeah. From the ASIS. Yeah, to to the medial condyle. Okay, so again, as you could see, there is a phone and other things, so that could have an impact on the score. Yeah, so that is fine. So we'll just need to be aware of that. Okay, and so we need to measure for the femur and compare with the other side. Yes, sir. What is the score?
Around 50 centimeters.
Okay, on both sides.
Both sides.
Okay, and then we are going to check for the tibial length, which will be from the tibial tuberosity to the medial malleus. Yeah, and then we check it for the other limb as well. The tibial tuberosity is something just below the patella.
Yes, the same.
Yeah. Okay. So just Samson had said, if it is more than 2 inches, then it becomes difficult for the person to use the wheelchair, because again we also have a knee support. So if the femur length is lesser, then one knee would be forward compared to the other knee. Okay. So then that will have an impact on the stability of the person in standing. And then once it is done, we go to the next check, so, which is the mechanical assessment tool. And we are going to observe the person's pelvis, trunk, and hip. So can you, so let's check about the pelvis now. So can you sit, sir, Mr. Manish? Yeah, and we would like to have a side view. So can you sit on some other, on the edge of the table facing on the side? Yeah. So now there are 2 things that we're trying to look at. One is the observation, and the other thing is we're trying to see if what we call as hand simulation. The hand simulation is the mechanical testing that we are doing to check how much support or what is the level of modification that is required. And so what you see here is we are looking at the pelvis tilt. Okay. And right now what you see is a neutral pelvic tilt. He's sitting with upright posture. Okay. And can you just move slightly forward? Can you tilt your, yeah. And once you're doing this forward and try to arch your back backwards. Your tummy is forward. Yeah. And the back is, yeah. So this is an anterior pelvic tilt. And once and now go to the other end, which is like slouching backwards. Yeah, this is a posterior pelvic tilt. Okay, so you see, if you can just keep your finger on the PSI, on the iliac crest, I think it will help people to identify it better. Now this is a posterior pelvic tilt. Now what you see is the finger, the index finger and the thumb of Mr. Dinesh. The thumb is lower than the index finger. This is a posterior pelvic tilt. And now come back to the upright position. Now they are at the same line. No, not forward. Upright. Okay, now when the thumb and the index finger are at the same line, it is the neutral pelvic tilt. And when it is anterior tilt, which is forward leaning with the arching of the back, backwards, that is your anterior pelvic tilt. And now what we ideally need is a neutral tilt. Okay, and so if the person is moving back, we are going to give some amount of force. Okay, so let me just show you that. So we were checking whether the pelvis is in a posterior tilt or a neutral tilt. And then, so can you go back to the posterior tilt again? Lean backwards, slouching position. Yeah. And Mr. Dinesh, can you just try to get him to sit upright without his help? He should not be contributing. It should be your effort. Okay. So get this into upright position. Yeah. And what you see here is when the person, the amount of force that you're giving, that will guide you in terms of what is the amount of support that is required, what should be the density of the foam that should be required. So that is the amount of force, and we are looking at 2 things. One is the amount of force, and second is the direction of force. Pushing it forward and slightly upward.
Upward.
Okay, forward and upward. So that would be the direction of force. Okay, and then you get this upright sitting posture. And then, so this is the pelvis tilt. Now, the next thing that you're looking at the pelvic obliquity. Now, Mr. Manish, can you sit facing the laptop? Okay. Now, the obliquity means that one pelvis is up, raised up. Okay, as if you can just tilt your pelvis slightly towards one side. Now, this is, as you could see, the right pelvis is lifted compared to the left. Now, this is pelvic obliquity, and this is something that we have to note down. And the third thing would be the forward rotation or of the pelvis. So, which means, can you just bring your one knee forward? Your right knee can be slightly forward compared to the left knee, but your trunk should be straight. Only the knee should come forward. Yeah, can you bring it a little bit more? I think it's not very obvious from the laptop. Can you bring your knee slightly, only the right knee forward? Okay. Now, when you do this, you see that there is a forward rotation of the pelvis. Okay, which shows you that the right side is forward compared to the left side. And you can also observe this from the top view. When you're looking from the head vertically down, then you can also observe this compared to the background or the wall. If the person is leaning, then you can also observe this. So next we look at the trunk. Because he's seated here, we would also like to look at the scoliosis. We'll look at that from the coronal plane. We'll look at the scoliosis. And can you just tilt your trunk to one side, like you're try to bring your elbow down to one side? Yeah, so this will be the scoliosis. And can you just turn to the other side so that we can see your back? You want to see your back. Yeah, and do the same thing. Yeah, so that would be your scoliosis. And then we will have to identify what is the peak or the apex of the scoliosis. Can you just find out, sir, Mr. Dinesh? Where is the tilt, the maximum tilt that you can see? Okay, and once you're able to palpate it, and then you identify which part it is, thoracic or lumbar. This is and we always name it on the side of convexity. So because it's tilted on the right side and the convexity is on the left side, this will be left thoracic scoliosis. Okay, and then we look at the next thing, which is your kyphosis and lordosis. So can you just sit facing this side view, so that we have a side view? Yeah. And so kyphosis would be again kind of slouching back and trying to bend forward. Yeah. And can you just that is fine. Okay, so this again is a kyphotic spine, and again you will note down which whether it's kyphotic or lordotic. Lordotic would mean there's an arching of the spine. So this is your lordotic spine. So you'll note it down. And the third thing that you're going to look at is the trunk rotation. Now this is the right shoulder that is forward. And so what you have to see from the top view, okay, from the head to the spine, and then you will be able to see that there is a forward rotation of the trunk, and you'll be able to measure that as well. Okay, so this will be for the trunk. And let me move on to the next one, which would be the hip. And here we are going to observe about the hip alignment. So as you can see, there is a slight amount of abduction, and there is a neutral rotation of the hip. And the hip is obviously in flexion because he is in sitting. Okay, so now this is what you can see right now. And then the other thing that you can see is this abduction too much or too little? Okay, because if it is too much, then what it will happen is this will have an impact. And can you just try to bring the hips together, the knees together, Mr. Dinesh? Yeah, knees together. Now let's imagine this person has a abductor kind of contracture and is not able to, or it could be some deformity as well, and is not allowing the knee to come closer. So can you just spread out your knee? Yeah, can you just spread out your knee, and now this time you're not allowing him to bring it closer. Okay, so you try to bring it closer, and you should not allow. Yeah, thanks. That will do. Enough. Yeah, so what happens is that now here this person has a deformity, and which is not allowing him to keep his knees closer to each other, and so this will have an impact on the seat width. That is something that we have to be aware of, and which we will discuss later. And the next thing that we're looking at the windsurf deformity. So when we're looking at the windsurf deformity, windsurf essentially looks at external rotation on one leg and internal rotation on the other leg. Right, the way he's sitting right now. So this is external rotation of both limbs. Okay, because he's crossed his ankle. Okay, this hip is moving external rotation right now. So windsurf means there is external rotation on one side and internal rotation on the other side. Now you can relax. Keep your legs apart. Yeah. And then, can you just, Mr. Dinesh, can you help him to get him to windsurf? So internal rotation on one side. Yes. So this would be a windsurf position. Okay. So the right leg goes into external rotation. The left hip is in internal rotation. So this will be a right side windsurf deformity. Okay. So what will be the left side windsurf deformity? Yeah. So this will be the left windsurf deformity. And once this is done, we go to the static balance. And what we are going to check is we are going to see if the person is able to sit without arm support. And then we have ranges like poor, good, fair, and good. And what we are going to check is the best response that you can check in this is if the person is able to sit and he's able to pick up objects from the floor, assuming that his feet is supported and there's a footrest. Okay, and we see that is he able to pick up something from the bend and pick up from the floor. Can you just give him something at the ankle level? Yeah, so whatever he has demonstrated already. Yeah, so that is the amount of balance that is considered to be the ideal. Okay, and then the other level would be which is fair, when which the person is able to weight shift. Okay, can you just shift your weight, reach out to the sides? Yes. And now can you just show your hand and ask him to reach out for something slightly higher? Yeah, so that there is not much of forward leaning. Yeah, that's fine. So there is a weight shift to the right side now. So that is what we're looking at. That will give him a score of fair. And then you look at these things. So picking up object, then looking at multi-directional reach. So he's able to reach forward, he should be able to reach sideways, he should be able to reach backwards. Can you just show all the three, sir? Forward, sideways, backward. There could just be a weight shift without a reach. The weight shift, the only thing that he is able to do. Can you just shift without reaching? Without reaching. Without reaching. Okay. So that is your weight shift. This is again a good way to identify if the person is able to relieve the pressure of their ischium or of their sacrum. So that would be a pressure relief. And what you're checking here is the weight shifting. And if the person is not able to do, if the person needs help to even maintain the sitting position, then it will be termed as poor. And once this is done, we go to the hand simulation. Okay, so we go back to the hand simulation. Is essentially what you are checking is the amount of correction that is required. Now you have, when you have done the checking of the pelvis, when you have checked the trunk and the hip, once you have done all the assessment, and now we have identified there is some obliquity, there is some rotation. What we have to do now is we have two questions now. Do we need accommodation or do we need adjustment? Okay, what do I mean by that is, can I make this person get over with this? Can I correct this obliquity? Can I correct this rotation? Okay, if that is not possible, then what you will do is you will accommodate. You will accommodate would be you will add some extra cushions, you will add some extra supports so that this, because the person has most likely has a deformity and that is not correctable, then you will accommodate. Okay, so that is the main decision that we have to make, and based on that we will have to give additional supports. Okay, so now we'll just look at the ischium. Can you just put his hand under the buttocks, sir, in sitting? And assuming you are tilted to one side. Okay, now this is an obliquity. Okay, because one side is lifted compared to the other, And then what you will do is you will try to see if you're able to apply force and get his alignment correct. So he's more tilted to the left now, and the amount of force that is required, that you will take note of that, and the direction. So there are two things always when you're looking at the hand simulation. One is the amount of force, and second is the direction in which you will apply that force. Okay, and is it correctable or not correctable? If it is not correctable, we'll have to go for accommodation. If it is correctable, we can probably work with some exercises from stretching and things like that. And then the next thing is we are going to look at the posterior superior iliac spine, PSIS. This is mainly for the tilt, again side view, but we want you to just, as if you're sitting on your sofa, just slouch backwards. You're relaxing and watching a nice movie. Okay, yeah. So, and now you apply force to get him to become upright. Okay, now what happens also is, can I have one more person? Ms. Nishanti, are you there?
Yeah.
Can you just come and stand in front of him?
Yeah.
Yeah, and can you support his shoulder? Yes. Okay, this is a posterior pelvic tilt and this is a slouched position. And now Mr. Dinesh is trying to get his alignment right and is going to apply some force. Now, what is the role of Ms. Nishanti is to make sure that the user does not fall, because user typically have most of the times have a poor trunk balance, and because the amount of force that's given is excess, we need to be aware of that there is a possibility that the user may fall forward. Okay, and that is what Ms. Nishanti is doing it. Yeah, please, can you do that now? Push from the back, and you're just going to make sure that the person is stable. Yeah, thank you very much. And then the next thing that we check is the iliac crest. So we put your hand on the iliac crest, and we're trying to see the obliquity here. Can you lift one hip slightly up? Yeah, and then we are trying to measure, check on both sides, and then apply pressure. So always in the form, it has been given as the amount of force and the direction of force. Okay, so we always have to be aware of that, and we need to fill in that. And next is the ASIS, which is the anterior superior iliac spine. From the front, probably you can just keep your fingers from the back itself. You don't have to come forward, because then you will not be able to see. Okay, or you're looking at the ASIS, and then you're looking at the position if is the person able to maintain that. And sometimes when you, as there was a question regarding the trunk support, if the person is not able to maintain this neutral alignment of the pelvis, and then we might have to give a pelvic strap. Okay, and that is why we need to check what is the alignment here and amount of force that is required. And then we look at the scoliosis. Again, turning, can you sit facing the wall and tilt to one side so that we have a scoliosis. Okay, and then you apply pressure on the apex. Yeah, and as you rightly did, you put your hand on the shoulder. Sometimes you might also have to support at the ribs. Okay, it depends on the person, where you give a counter traction, and then you see if are you able to get his alignment right. Okay, can you just do this one more time? So you note down the amount of force and the direction of force. And then we look at the ribs and the thoracic spine, the upper ribs, and look at all those things. And then you look at the scapula. Okay, now what can happen is, can you ask him to keep one scapula closer to his spine, like adduction of scapula? Okay, yeah, just bring the shoulder back, and then you will get that. So what you will see here is one scapula is closer to the other compared to the other scapula to the spine. Can you just get his spine straight now? The scapula with equal distance from the spine, and based on this, you will decide whether you need the height of the backrest. If there's a considerable amount of effort is required, then you might need a higher backrest. And the same applies with the mid-thoracic spine. Yeah, so if there's a kyphotic spine and you're trying to apply pressure and get in right, this will determine whether you have to apply the backrest angle. What should be the backrest angle is based on the kyphotic spine. So all these things will have a bearing on the angles or adjustments or modifications that we are going to make on the wheelchair. And then we look at the abduction. So can you sit facing the camera? Yes, and again, if as I had said earlier, like if the person has legs widely abducted, can you just spread your legs out? Okay. Yeah, if it is widely abducted, and let's assume that it is not correctable and external force cannot be applied to correct this, then what you see is then this will have an impact on the seat width. And the typical measurement is the widest part of the hip. That is what we actually measure for the seat width. But in this position, because the hips are abducted, we might have to take this into consideration as the widest part for measuring the seat width. And then we look at the adduction. Can you just bring both your thighs closer together? Okay, now this is what you see, and the default cushion that we have in Arise has a spacer between the thighs. But sometimes if it is too much, then we might have to give a adductor or a abductor spacer, which is also called as the pommel. Okay, so can you just imagine that you have something in between the legs, between the thighs? Yeah, so that would be the pommel, which will make sure that enough space is there between the thighs. So that could be an additional modification that could be required. And then when you look at the last thing, that would be the windswept. Okay. And yeah, can you just get into that windswept position on the left side? This is windswept. So remember Gandhiji's position. That's why that's how I tell everybody. Okay, so windswept position is now if it is less than 5 degrees, I think it is possible that you can continue with that. But if most of the case, if it is very severe, then the person may not be suitable for using Arise. Okay, so these are the assessments that we are doing. And once it has all been done, then you identify what are the problems, and then you look at whether this person is ready for using, or you have to postpone your selection, and finally whether this, or you reject the person based on this. So initially there can be one level of screening when you're looking at the medical conditions like osteoporosis and things like that. And there can be, during this assessment on the mat and the hand simulation, you can identify that there are certain things which can be corrected, or there can be certain modifications that are required, based on which the person will be able to use this wheelchair with modifications. And probably at some other time you will realize that this person is not suitable for Arise. Yeah, so with this we conclude this demo. Thank you very much for the demo, Mr. Dinesh and Mr. Manish.
So we can carry on to the next section, measurement.